everyone. Thank you for joining me in Vegas after lunch. This is really a hard time slot to be in, so I appreciate you guys all showing up today. I'm going to review with you guys just some different steps we've taken. At my institution, I'm at Florida Cancer Specialists and Research Institute. We have about 100 outpatient oncology clinics, and I'm the Senior Director of Care Coordination there, so I oversee our nurse navigation program, our remote triage program, nutrition, behavioral health, and our supportive services team. So in all these different areas, we have remote workers that are helping support our clinics and our patients across our practices. So during this talk today, we're going to help you understand the different components of a business case so that you can really go in and advocate to your institution if you don't already have navigators in place, or maybe it's that you want to ask for additional navigators, or even just start that conversation with your facility on how you get those vital resources of navigators for your patients. We're going to talk a little bit about the different payment models that people have used for navigation in the past. They're not super straightforward until now, where we have some codes for navigation, but there are other ways that people have had some of these services reimbursed by CMS. And you're going to help you to develop a better understanding of that navigation reimbursement and those new codes that have came out. So I'll try to go through some of this in the beginning pretty quickly so we can focus a little bit more on the end about those new G codes, because that's usually at my talks what people want to know most is, how do I get those going? Can we use this in my institution? What are some of our lessons learned? And we've been using the new G codes at FCS for about 6 months now. We started in February, so we will be able to share some of our lessons learned as kind of early first users of these new codes. So anytime we're going to do a business case, we really have to do these three things. We have to start with our SWOT analysis. We need to figure out what is our return on investment, and we have to look at our KPIs, which are our key performance indicators. So as we're going through this, I really like to have you think of, first off, of who is your audience. This conversation is really different depending on who you're speaking to and what you want as the end result of that conversation. So for your executives in your healthcare system, the questions they're going to ask you most likely are going to be, how much is this really going to cost me? How is this going to benefit our facility specifically? And what is the competition doing? Every time I talk to a CEO at a different institution, they're like, what are they doing across the street? Because I want to have what they have, or it has to be better than that. So come in there prepared with what's going on in your market, and then ultimately want to know, how does this benefit their patients? Conversation is just a little bit different when you go over to your providers. The providers ultimately want to know, how is this going to help their practice? Again, what's the benefit to my patient? And the big question we get all the time is this going to make more work for me or my office? They always want to know, like, is this just going to be one more phone call, one more email, one more thing that I have to sign off on? So really helping to set some clear expectations with your physicians up front. And then again, the question is, who's going to help pay for this? So when you're getting ready to go out there and have those conversations, you want to take a first look at those strengths of your current program, if you have one in place. And if not, just what's going on in your institution. What are some things that you guys are doing well? And I'm speaking from an oncology perspective, but you could really apply this anywhere. I know some of you specialize in sickle cell, arthritis, allergies, those different things. So you could really use this in any of those different areas that could require patient navigation. You really want to think about what sets you apart from your competitors in the community, and what are the good qualities of your hospital, your facility, or your program. Do you already have maybe a patient grant program or a nonprofit that you're connected to? Do you already have volunteers that give rides? What are some of the good things that you already have that you can tap into? Then you're really going to look at, what are your weaknesses? What areas need to be improved in your organization? Are the resources adequate that you have? You know, if you have rides for your patients, is it a volunteer that's only available on Mondays? Do you have access to grants? Those sort of things. And if you don't, what do others do better than you as well in your community? So you can say, hey, our competition across the street, they have navigation already, or they have X, Y, Z. And that's really good to understand what your weak areas are. When you're looking at your opportunities, you want to think clearly, what are my goals? What are my goals of setting up this navigation program here? How will the demands or the workflows be shifting? So is it something that your nurses or your patient coordinators or your financial navigators or advocates are going to have to take on that they weren't doing before? Is it just a little tweak in their workflow? Is it maybe combining roles and responsibilities? How are those demands really going to shift? And then what could be improved in their current workflows? Our next area to really focus on is, what are the blockers or the threats that you're facing as an institution? Are there factors outside of your control? When we go through this, are there some things that you can't do because your institution doesn't allow it? Are you maybe in certain value-based care programs or different contract arrangements, and there are certain things you can or can't do because of those definitions of those contracts? So really just know, what are some factors that you cannot control. And while you're doing this evaluation, what I always say is there are things that you can currently measure where you're at, even if you don't think you can, or you don't think, oh, I don't have a cool software or tech tool. There's no way. We don't have any data, some baseline data. We started, just like most of you probably, with basic Excel spreadsheets or notepads or wherever you have to start, where you really look at like your timeliness of care for your patients. How long did it take them from their diagnosis of whatever process you're looking at to their first treatment? What barriers did they experience? So keep track of those things. And then as you make these changes, you'll have that initial starting point data to show how your navigation programs made a difference. Patient feedback surveys are really important to get their acknowledgement of what issues they're experiencing up front and in their care right now, and what gaps they are experiencing as well. We want to make sure you have a good understanding of your current workflows and any technology you have in place or lack thereof, which most places it's more lack of those technology pieces that we need. So we talked about those key performance indicators, so we're going to touch on those. What are things you can measure? Because anytime you're going to show data or say, hey, I want to start this new program, or I want to hire some FTEs so that I can provide this service to patients, and for most part, people don't know that there is some reimbursement out there for this, so sometimes you're coming to someone saying, hey, give me X amount of money to hire staff, but I don't know if I'm going to get you anything back in return for it up front. So it's really, you got to make sure you understand what you can measure to show them those maybe non-financial things that you're helping improve. So those are those resolved barriers to care. Those are things you can count. Like we had 10 patients last month that weren't going to make it to their treatment, and we would have lost maybe that drug or that medication because we had to discard it, but we were able to get them rides. So maybe we didn't show you money for that FTE, but we saved that treatment, we saved that patient's opportunity. Look at their time from diagnosis to first treatment. We know that the quicker someone's able to have that first treatment from their diagnosis, their care outcomes are better, their chances of survival increase. So these are some things that you can measure. You want to look at your number of navigated patients that are readmitted to the hospital. So many of our contracts out there now want to know, are we making a difference on our ER and inpatient utilization rates? So measure, when you provide a navigator to a patient, do you see a difference in if they go back to the hospital or if they go in the first place? We've been using an ADT feed to really help us track that information of patients that are getting into our local community hospitals. Again, those ER inpatient utilization rates are really helpful to measure. We look at distress screenings as well to see if we had improvements in the patient's level of distress when they had a navigator assigned. We also look in the oncology space at our number of palliative care referrals. And then again, we want to measure that patient satisfaction because always their voice makes the biggest difference in this whole process. So I just threw this in here for you guys, and you'll all have access to the slides. Still, everyone wants to know, what's the return on investment? How much am I going to make off of this? And it's not really clear. It's not black and white. It's really hard to say, hey, if you give me 5 navigators, we're going to give you $1 million in revenue right away, or in a year from now. That's really hard to say. But there is a lot of research and studies out there, and there are sources that you can click on the slides to see where I pulled these from. But there are academic papers out there that show early intervention of breast cancer navigator at Henrico Doctors Hospital decreased the migration rate from 240 to 28, which resulted in $350,000 in billable procedures in 1 year. So there's a few of your FTEs right there. Navigation from time of suspicious finding to the entire care continuum equaled a $3,000 greater contribution margin. That was another piece of data pulled from another paper. And then we saw a decrease in clinical visit time. So when a patient has a navigator assigned and they've already had some education before or after they go into an appointment, the time they're actually spending with the physician face-to-face to review all these things, we've seen a decrease because they felt like they went into their appointments and they had their questions answered. They came in prepared, they worked with their advocate, and they knew a little bit more by having that advocate with them before they went to that appointment, which saved that clinic time and the clinician time, and he was able to see maybe another patient in that next spot. And then again, I just like to give you guys resources because as you're building your business case, it's always good to know what are other people doing, what are metrics. So these are from AONN and the sources at the bottom, but these are some of the different navigation metrics that they measured in a task force and an early pilot, very similar to the ones we talked about, and they kind of tell you where you can start to get those measurement pieces of data from and how to do that. So this gives you, they looked at those barriers to care, they looked at that diagnosis to initial treatment, the navigation caseload, because when you're figuring out the business case, you need to say how many patients on average can a navigator handle. If it depends on your disease site, it depends on what they're navigating. An oncology patient may be a little bit different than an arthritis patient or an allergy patient or your pediatric patient. Their needs are going to vary based on your population. So you really have to figure out what's that length of time that's like that sweet spot for that patient to be with their navigator during their treatment. And that will change your number of navigators that you need. Again, you really want to look at that number of patients that go back to the hospital. Everyone's asking that nowadays. So if you have a way to track that early on, it's going to be really beneficial for you in the long run. We want to see those psychosocial distress screenings. We want to see those social support referrals, palliative care referrals. Did we help the patient with their learning styles and their education? Did they learn something because we were able to speak to them in their language that they could understand and really give them the resources that they needed before their appointment? And what did they know before they met with you to where they are now that they've had you as part of their care team? These are just some of the different metrics you guys can use as you start to do this. So I'm going to get a little bit into the payment models and what some other practices have used to get reimbursed for some of these care services. Not an expert on these things, so I'll put that out there right now, but these are things I've learned from other practices of ways that they've helped support some of their programs. There are very specific rules and guidelines for some of these different programs, so I do want to refer you guys back to the CMS official page so you can get these guidelines for yourself to make sure when you set your programs, you're following all the exact requirements. But principal care management is a service that focuses on patients with chronic conditions who require care outside of the primary care setting and require a specialist intervention. These are usually provided outside of face-to-face patient visits. And to have these characteristics for the specialty, you need to be able to show that they had 24/7 access to care and health information, there was patient and caregiver engagement, they receive preventative care, you have to be able to show that you've timely shared that patient's health information, and they have to have that continuous relationship with a member of the care team. So for a patient to be eligible for principal care management services, the condition has to be expected to last between 3 months and 1 year or until the death of the patient, and they have to have a chronic condition that resulted in a recent hospitalization or places them at a significant risk of death. And there has to be some kind of chance of decline, and this is why we're providing these services. There's a lot of criteria with this. This is not a program we've traditionally done at our practice because there are a lot of different requirements, and it's not something that can just be done by everyone. The patient does have to consent to this. There has to be an initiating visit, and they have to have not been seen by someone else that has billed for the same code in the same time. So that's part of it. You could be doing these services, and then they may have a PCP that also has them enrolled in a principal care management program. So this is one we're not personally using, but it's out there. So do a little more research if this seems like something that would work with your institution. You have to provide a care plan. You have to provide that 24/7 access to physicians or qualified healthcare professionals. So they have to have access to that on-call nurse, on-call physician. What that looks like at your place may be different. And they have to have ways to communicate through telephone, through secure messaging, and be able to reach their providers. And then when you document for this, it requires these different things here. I'm not going to read through all of them, but as you can see, you have to make sure you've checked these boxes of documentation to ensure that these billing codes will be eligible for you. Another one that's been traditionally used to help support navigation type services or care management services is chronic care management, or CCM. This one requires an initial in-person visit for new patients or patients not seen with the billing practitioner for 1 year. And then they have to have 2 or more chronic conditions. So the big difference here is 2 or more conditions versus the other one has 1 condition. So this is one you would want to look at if your patient had 2 existing comorbidities that really put them at a higher risk. And these services, again, aren't typically face-to-face. So this is another one we're not quite tapping into, but I've heard of other practices that have really strong principal care management and chronic care management programs. This is reimbursement that would involve physicians, nursing, that type of staff. TCM, or Transitional Care Management, is a program that I'm familiar with and that we have deployed at Florida Cancer Specialists. So as I mentioned before, we have a ADT fee that's helping to alert us of patients when they enter our area hospitals. It gives us those real-time alerts. So we have our patient roster that we provide to this company, and then they kind of cross-reference it so that if one of our patients happens to go to the hospital, we're able to say, hey, here's a little trigger. Sally went to the hospital today. Have a nurse reach out. So again, we'd love to get them before they get to that point, but this is at least letting us know if one of our patients has hit their system, and we're able to assign a nurse. In our case, we have LPNs calling and reaching out to these patients and providing a 30-day post-discharge phone call, communication, active participant in their care. And big thing we've seen with this program is making sure that when that patient leaves the hospital, that they have that follow-up visit set with their oncologist. Before I came on board, they had a little bit of a TCM program going, but in the beginning it was like, okay, so we saw you were in the hospital, make sure you call your provider and set up that appointment. How many patients do you think made that phone call and set up their own appointment after they just got out of the hospital? Like none, maybe 2. So we looked at that and we're like, we can't put that on the patient. That's one more step for them to do when they've gotten out of the hospital. They have a lot going on, one more thing for them to remember. So we changed that whole process. And now before they get off the phone with my team, they have an appointment booked. They know when they're seeing their provider, and that follow-up visit, we're making sure we're calling them along the way to check in on them, making sure that they have a ride to that appointment, if there's any barriers that are preventing them from going, and they're making sure that they understand their discharge instructions, because we see that's a big gap too. So many times they're rushed through the hospital, or they went to the ER in the middle of the night and they get sent home and they still don't feel the greatest. We don't want them to have to go back there. We want them to let us know so we can help them and manage their problems right away. So what we found in doing this was that the TCM codes, so when we're talking about billing codes, are actually worth a lot more than our traditional E&M codes that our physicians were using for their hospital follow-up visits anyway. So a lot of times our physicians were catching these patients, maybe not as quickly, maybe not checking all the TCM boxes, but once we kind of put this process in place, we were able to say, hey, doctors, like if we see this patient within this time frame that's required, if we get them in faster, if we do these things, we can bill for this a little bit differently. And as you can see, it's almost double, a little bit more than double in some cases. So for the providers, all we had to really say was, hey, you're gonna get paid double if you do this quickly and you get these patients in right away. And we were able to make a big change for the patient and for this program. So we'll touch on these billing requirements here. A TCM nurse must attempt to contact the patient within 2 days post-discharge from an acute setting, and patient has to be seen by their provider within 14 days post-discharge. So this program is all about timing. You have to really make sure that the patient's seen in a timely manner. Payment is based on the first submitted claim. So their PCP, if they have an oncologist or another physician, they may be trying to get them in the same kind of program. So really it's whoever submits that bill first in the first claim. If you receive a denial from the insurance company, you can recode it to a normal E&M office visit code because the physician is still seeing that patient in the office and that care is still taking place. It will just be at that lower reimbursement rate. So these are things that have been around for a while, but not everybody has tapped into to the full potential. And as some of you know, we had some people speak on the moonshot here. Part of the moonshot effort is the president and everyone came up with some new G codes that actually cover navigation services. So this is called Principal Illness Navigation, or PIN services. And you probably heard a lot about this, different avenues. This is really meant to help oncology patients and others, or others with a high-risk condition. So I'm just going to say that because I know we have lots of different populations here, but they must have a serious high-risk condition expected to last for at least 3 months that places them at a significant risk of hospitalization, nursing home placement, death, functional decline, those things. They still have to have a disease-specific care plan. So I know I've talked to a lot of you about starting this up in your different areas, or you're an advocate and you want to know if this is something you can maybe bill for. These are things you'll have to make sure that you're able to do. You have to be able to provide them a care plan that could require some frequent changes. And they have to be on some medication, some things that you're monitoring. And right now, these codes are approved for Medicare patients, but we have started to see some of our commercial payers start to pay for these. I think there's about 7 or 8 payers that committed to the president, and there was a press release for the moonshot saying that they were going to honor this. And there have been a few that we've submitted claims for that have worked out and that we have started to see reimbursement from commercially. So for the Principal Illness Navigation, patient consent is a must. It has to be written or verbal. In my practice, we've started with a verbal, and we have that documented in our EMR. And before the PIN service can start, the practitioner must perform an initiating visit. So if you are a standalone advocate or you have your own private practice somewhere, you still need that physician referral and you still need that initiating visit to take place. So that's a big part of this if you're trying to think of how can I do this in my independent practice type setting. The treatment plan must be completed for the patient, and the documentation in the EMR must include the time you spent providing PIN services, the activities performed by axillary personnel, and how activities were related to the treatment plan, and if any SDOH needs or social determinants of health were present. So that's like housing, food insecurity, those things. If those things were addressed with the patient, it needs to be documented. So then I just put on here for you guys so you can start to do some of the research on your own about these codes. So the big thing here, and I didn't lay out all the different requirements, there's a lot to this, but the first step is making sure your personnel, and this does not have to be a nurse, this does not have to be a licensed, registered person. The first requirement is that they have to take a navigation certification course. So in your states, the requirements vary for that of what constitutes as a navigator or social work type course. Each state even calls it something different. What we did for our team, there was a free course through the George Washington University. So we started there and we had all of our staff take that training. There's also a course through American Cancer Society, their Lions program. AONN has a course as well, and NCBC has a navigation course as well. Some of the others cost, where George Washington was free, so that's kind of the route we took to get ours started. And we trained both our nurses and our supportive care team. Our supportive care team are our patient advocates. Maybe they don't have a clinical license, but they've had that navigation course and they're able to provide these billable services. So that was our first step. And then when we got everyone certified, we made sure our EMR was correct, we got our documentation in place. These are the billing codes that are in place now for us to use. So the G0023 is for that first 60 minutes, and then G0024 is for every additional 30 minutes, and that's unlimited. So that first code, I think, is around $80 is what we're seeing reimbursed for that first code, and then it's around $45 to $50 for that additional 30 minutes. So hasn't been a huge ROI. It hasn't been like ground shaking to where I've been able to say, I can pay for 5 FTEs with all this money reimbursement we've gotten. No, we're actually one of the first places that we've heard that have actually started utilizing the billing codes and dropping them and really building this program up. Has it helped offset some of the costs? Yes. Has it helped provide these services for the patient? We were doing this already. So that's the great thing about where I was. We already had navigation. I didn't really have to give them the business case. Our leaders believe in this for our patients, and they knew it was the right thing before there was any reimbursement or any codes or anything attached to it. So we were doing it regardless, but it's really great as a leader if you can go back and say, hey, we're doing really good over here and we've got these codes. Let me show you how we can get a little bit back for that. So now we've started doing that, and it's really gained some attention. Even nationally with the moonshot efforts to say, now that we've had about 6 months in, we're gathering our data to see how many SDOH problems were identified, what barriers did we remove, what populations are we seeing issues in. So this has really helped us to really gather better data on our patients too, and see how we're best serving patients with these needs. So there's a lot more to this and a lot more that we can't lay out probably in a 30-minute session, but I have my contact information on there as well, and I want to give you guys some time for questions too, because there's usually a lot of questions about this. So I will open it up with that, and then my contact information is here as well. So anyone has any questions? They should be on the app, right? Do you guys put them on the app? If not, you can email me. I have no problem sending them to you too. My email's on there.
I heard somebody else say that, and I was curious. It's on Snapchat for a year. Is it where? All of the seminars in the summit will be on Snapchat for a year.
On Snapchat?
That's the app.
Oh, Swap Chat. I don't think it's Snapchat. I'm like, oh, it's a different platform. Yeah, I want to put them on Snapchat so they disappear after you look at them for 1 minute. Never see it again. Yeah, go ahead. Can we get some mic?
I can just talk about it. I'm just curious to know.
AV, mic check. I think she might be asleep.
I'm just wondering, do you get a lot of pushback from your physicians as far as completing care plans?
So our physicians were required to complete the care plans. Oh, sure. Sorry about that. She asked if we get a lot of pushback.
Can you hear
from
me
our
now? Okay.
Do we get a lot of pushback from our physicians for completing the care plans, having to complete the care plans as part of this process? We required them to complete care plans ahead of time. I would say in our lessons learned from this, we're such a big practice that the physician referral piece could be a problem in the beginning, because even though we have these great services, sometimes the east side of the state doesn't know what the west side of the state's doing, and we can tell them 20 times in emails and huddles and all the things, but they don't know all the things until they start using it. So for us, it was more communication and reminding them of those referrals and how to educate them on putting in the navigation referral, because before we were doing this already, and they didn't have to really refer anyone to it. It was just a service we were providing. So there's some extra steps we had to put in. So they have to now click 2 more buttons, and that's really hard. And so there's some extra steps that they have with that. But to help with that, we created a standing order for them, so that way if patients meet certain criteria, they don't have to hit those 2 buttons, 2 or 3 buttons, and there's an order there for that. So that was kind of our workaround for that. And I'll also make sure that nobody is missed. So we are actually risk stratifying our patients too, because we have such a big patient population that I don't have enough navigators to serve the 90,000 plus new patients we see a year. I wish I did. So right now I have to be, as a leader, thinking, what patients can this make the biggest impact on? So we have some different clinical risk criteria that we've set, and we have an amazing informatics team that's helped us build some really cool tools that help us see which patients qualify or should get the service. And so we, based on that, set a standing order that if a patient falls into our high-risk category, navigation is an automatic referral. So that's kind of helped give them another easy button. I always say for your providers, we have to find those easy buttons for them. Like navigation should be an easy button. They should all want us. And once they see how it works, they usually do. But in the beginning, when there's one more step or one more click or button or something, it can get a little pushback there.
Thank you.
You're welcome.
Thank you. Yeah, and you may have covered this regarding these PIN codes. How much does CMS reimburse for these?
Yeah, so that first code for the first 60 minutes, it's been running around $75 to $80 for that first 60 minutes. And then the additional 30 minutes has been about $45 to $50. And we have seen reimbursements. That's the big question I get too, is no one can find anyone really out there that's been doing this yet. We've been doing it since February. So we have seen reimbursement. We've even seen it from some of our commercial payers too. So it's really exciting. That's starting to catch on. And we really are trying to get the word out there, because like we know with some of these codes, if people don't start using them and figuring out ways they work in their practice, there's a risk that it could go away, which we hope not, because this is the first step. And when I talk to Annabella and others from the Moonshot, they're like, this is our first step at tackling this really big problem, and how do we provide these services? So this is a great initial step. But from there, we're all providing comments that we're using them, like saying, hey, it's hard to get to that first 60 minutes sometimes, or maybe these codes could be worth more in the future, but right now this is a great first step for all of us. So thank you.
Oh,
I think
one more. Hi, do you provide patient assistance program or copay, co-insurance help?
Yeah, so we have different programs that we use right now, and we do have some different partnerships. I know our facility has relationships with different companies and everything, but we do have different patient programs that cover those things. And then we also have a nice non-for-profit as well that is associated with our business too, that patients can apply for grants for non-medical needs.
Any more? Okay.
All right, thank you.